So welcome and thank you for joining us today for the meeting of the New York City Health and Hospitals Medical and Professional Affairs and Information Technology Committee. Today's meeting is officially called to order. Bylaws Section 14 on committee attendance. If any member of a standing or special committee of the board will not be present at a scheduled committee meeting, the member may ask the chair of the board to request that another board member, not a member of that committee, attends a scheduled meeting and be counted as a member for purposes of quorum and voting. Therefore, she's on the way. Therefore, Dr. Calamia has requested that Molly Wasso Park, represented by Karen San Hilaire, be counted for the purposes of quorum and voting on his behalf, and that request was approved. So I would like to propose a motion to adopt the minutes of the MNPA Information Technology Committee meeting held on September 9th, 2024. Dr. Katz?
Yes.
Sally Hernandez Piñero?
Yes.
Jose Pagan, yes. So minutes approved. We will now consider an action item. Ms. Yan, please read the resolution into the record and proceed with the presentation.
Patsy.
Good morning. I'm Patsy Young for Correctional Health Services, and presenting is Timothy O'Leary. He's our Chief Financial Officer.
Hi, folks. Here's the resolution for your consideration today, authorizing the New York City Health and Hospitals Corporation, the system, to execute a best interest renewal with Physician Affiliate Group of New York, PC, for physical and behavioral health services at correctional health facilities for a not to exceed amount of $622,600,000 for a contract term of 3 years and 3 one-year renewal options exercisable at the discretion of the system. So some background for you all. CHS was established as a division within New York City Health and Hospitals in August 2015. A primary impetus was to improve the quality of care by directly providing services rather than through a contractor. To support this goal, all management and supervisory staff, as well as many frontline staff, are direct health and hospitals employees. However, some of the frontline staff whom CHS selected to retain were employed by the contractor. To avoid disruptions in patient care, it was important to preserve the benefits of these employees. CHS therefore selected PAGNI to employ these individuals. CHS staff employed by PAGNI are strictly frontline patient care personnel in medicine, mental health, and social work, and are members of 1199 and Doctors Council. PAGNI staff comprise about a third of the CHS workforce. CHS's contract with PAGNI is limited in scope and ensures a high level of transparency and accountability. The PAGNI contract for CHS is limited to personnel and payroll services. The staffing plan is established, reviewed, and finalized by CHS for PAGNI's implementation. CHS maintains a close relationship with PAGNI for overall human resources and labor relations actions, policies, and procedures involving CHS staff. CHS establishes an annual budget for PAGNI consisting of payroll expenses as well as allowable overhead and admin costs, which have been capped at 2.75% since inception. And CHS receives and reviews PAGNI's biweekly payroll and financial expenditure reports, along with all of its CHS-related books and ledgers. The contract expires at the end of the calendar year, and there are no more renewal options. New York City Health and Hospitals and PAGNI entered into an agreement for an original 3-year term starting in 2016 and ending in 2018, with option to renew 3 times for successive 2-year terms. We have exercised all of these renewal options that you can see here. New York City Health and Hospitals reimburses PAGNI for their financial outlay for authorized expenses. PAGNI expenses are shown here ranging from $85 million to $97 million annually over the last 5 years. CHS regularly audits and reconciles payments to PAGNI as part of our ongoing financial review of its expenses, and all of CHS's operating costs are fully reimbursed by the City of New York. Under operating procedure 100-05, the system can renew a contract with appropriate vendor and pricing due diligence rather than re-procure when it's in the system's best interest to do so. And it is in the system's best interest to continue with the current arrangement. To repeat, the renewal will ensure a continuation of services for CHS patients provided by PAGNI staff. CHS's contract with PAGNI is limited in scope and ensures a high level of transparency and accountability. And the administrative costs have been capped at 2.75% since the inception of the contract. Here is the vendor performance evaluation. We've rated them satisfactory. Here's the vendor diversity page pursuant to the vendor diversity policy. Clinical services such as these are exempt from the vendor diversity program. And lastly, again, the resolution for your approval. I can repeat it if you like. Authorizing New York City Health and Hospitals, the corporation, Health and Hospitals Corporation, the system, to execute a best interest renewal with Physician Affiliate Group of New York, PC, for physical and behavioral health services at correctional health facilities for a not to exceed amount of $622,600,000 for a contract term of 3 years and 3 one-year renewal options exercisable at the discretion of the system.
Thank you. Any questions from board members? From committee members? Okay, hearing none, let's ask for a vote. All in favor, please say yes.
Yes.
Opposed, say no. This resolution approved. Thank you so much.
Thanks.
We're gonna move to Dr. Allen, trauma centers. Dr. Allen. This will be one presentation on the trauma centers. So can you read the
Sure.
resolution?
Approving the application of New York City Health and Hospitals Corporation, the system for verification by the American College of Surgeons, ACS, of New York City Health and Hospitals, Bellevue, Elmhurst, Jacoby, Kings County, and Lincoln as Level 1 trauma centers, committing to maintain the high standards needed to provide optimal care for all trauma patients, and that the Multidisciplinary Trauma Performance Improvement Program has authority to evaluate care across disciplines, identify opportunities for improvement, and implement corrective action plans. Authorizing the appropriate officers of the system to execute any and all documents necessary to verify Level 1 trauma center designations for Bellevue, Elmhurst, Jacoby, Kings County, and Lincoln through the American College of Surgeons Committee on Trauma.
And then for level 2,
For the Level 2, approving the application of New York City Health and Hospitals Corporation, the system for verification by the American College of Surgeons of New York City Health and Hospitals Harlem as a Level 2 trauma center, committing to maintain the high standards needed to provide optimal care of all trauma patients, and that the Multidisciplinary Trauma Performance Improvement Program has the authority to evaluate care across disciplines, identify opportunities for improvement, and implement corrective actions, and authorizing the appropriate officers of the system to execute any and all documents necessary to verify Level 2 trauma center designation for Harlem through the American College of Surgeons Committee on Cancer. And finally, approving the application of New York City Health and Hospitals Corporation for verification of the American College of Surgeons of New York City Health and Hospital, Bellevue, and Jacoby as Level 2 pediatric trauma centers, committing to maintaining the high standards needed to provide optimal care for all pediatric trauma patients, and that the Multidisciplinary Trauma Performance Improvement Program has the authority to evaluate care across disciplines, identify opportunities for improvement, and implement corrective actions, and authorizing the appropriate officers of the system to execute any and all documents necessary to verify Level 2 pediatric trauma center designation for Bellevue and Jacoby.
thank you. Presentation.
Introduce yourself.
Okay. Good morning. I'm Dr. Sheldon Tepperman, the Chief Trauma Surgeon for New York City Health and Hospitals. I want to thank the board, the committee, say good morning to Dr. Katz and my friend Dr. Allen. I was asked to just provide a little background on what our trauma centers are, what the ACS process is. Let me just say that working with Dr. Katz and Dr. Allen over the years, we have built an incredibly robust and wonderful trauma system that takes care of all injured New Yorkers. I am very proud of what we've built together. Just to give you a sense of how this works, these are the trauma centers that Dr. Allen just spoke about, right? And we are 5 level 1, 1 level 2, and there's 2 pediatric trauma centers. And it always, every time I look at this slide, it looks like Harlem and Lincoln are twins. But I assure you, there's a raging East River that runs between them. And you can see that the city is well covered by the H&H trauma centers. Next slide, please. So this is the book, I call it the regulatory book. It's the gray book. So it's promulgated by the American College of Surgeons. I was just out in Dr. Katz's old haunt in San Francisco for the American College of Surgeons. That meeting is about both my learning from our colleagues, but also hobnobbing with the bigwigs of trauma and to make sure that they know that Health and Hospitals is here and has a robust trauma system. So that organization and its Committee on Trauma are the folks that make what is essentially the regulatory book and creates this verifying system. It is a very rigorous process. Presently, it's done remotely. There's a very rigorous pre-visit questionnaire you have to fill out, and then a 2-day, very, very rigorous inspection. And that is it's a 3-year cycle. Next slide, please. So the way this works is, the American College of Surgeons comes in and checks to make sure that all the rules in the book are being followed by our trauma centers. And as you see here, this book, the Optimal Resources Guide, is codified by reference in the New York State 408 Health Code regulations. So it is, in fact, the regulatory book. And I was just at the State Trauma Advisory Committee in Albany, where locally we review all of this. So again, the American College of Surgeons Committee on Trauma, VRC, comes in and verifies that we're following all the rules. And then essentially, state comes in and rubber stamps that the rules have been followed and designates the trauma center according to that level. Next slide, please. So the reason why I'm appearing before you so soon, I was here last year, not that I don't enjoy these encounters, is that there was a rule change in the book which required us to list the level of verification. And I'm here again just because we need to sync up. So there's that rule change, and that's why we're here so soon. Next slide, please. So just very quickly, a little bit about what our trauma centers do and the special things that they're required to do because we are verified by the American College of Surgeons. So our level 1 trauma centers are required to innovate and advance trauma care through research and scholarly activities. And I'm very proud of the fact that we are absolutely leaders in creating opportunities through our fellowships and our residencies and other training programs for the development of future trauma leaders. Next slide, please. So one of the many things that we're asked to do by the American College of Surgeons is to do outreach in the community, and we all must do injury prevention. And one of the most common things we do is a program by the American College called Stop the Bleed, which is a way to teach members of the public how to stop life-threatening hemorrhage. And then again, we are asked to train the next generation of physicians, surgeons, and subspecialists. Next slide, please. So I'm going to land on this for a moment because, as you noticed, and Dr. Allen read into the record, the part of the resolution about performance improvement. So trauma, PIPs, performance improvement and patient safety, must be independent but report to the hospital PI program. So if a center was to fail their verification visit, they would fail because their performance improvement is not adequate. So the American College of Surgeons recognizes that trauma is both an art and a science. And there can be, if you remember the movie, glitches in the matrix. So they don't find fault with the fact that we occasionally have a glitch, but they want you to be open and honest about making repairs to those glitches, whether it be a question of personnel or supply chain or some kind of systems error. And I'd like the board and the committee to know that this resolution you're passing for us is a living document. I have many, many times pointed to the resolution on a slide in the meeting. That was when we were doing them in person. and said, look, it's not just me performing this work, but it's Dr. Pagan and Dr. Katz and Dr. Allen and the committee that asked me to do this work in an honest and open way so that we can have better trauma centers. And actually, with that, uh, I think that people are more willing to participate in these opportunities for improvement. So the performance improvement we take very seriously, as the college does. Next slide, please. So then just finally, this is just a very few things of this, very few of the very special things that trauma centers need to do and the intense resources that we need to have in place are the following. So the OR has to be available within 15 minutes and ability to open up a second room if necessary. At all of our trauma centers, the operating room is available not in 15 minutes, but in 5 seconds. The blood bank, sometimes you hear on TV that, some terrible thing has happened at Lincoln, Jacobi, and one of the other places. Our blood banks through Kemper Ford are incredibly robust. I have never run out of blood. We have to have very intense radiology. MRI has to be available immediately, CAT scan available immediately, interventional radiology. And we all have very special equipment that is needed to take care of the injured patient. And all of our trauma programs have a very robust data gathering system, a trauma registry system, and very robust program offices with nurses that oversee all of this programmatic work. Next slide, please. So, Dr. Allen, this is just a repeat of the basics of the resolution. There again, we're showing you that the committee and then the board is authorizing us to do this work, to continue our work with the American College of Surgeons Verification Committee. I spoke to you about the importance of performance improvement, and that the board authorizes the executives here to execute all the documents. And I thank you for your time.
Thank you. Any questions?
Very quick question. What would it take for us to have a level 1 pediatric trauma center, and are we moving in that direction?
So that's an excellent, that's an excellent question. So the difference between a level 2 ped center and a level 1 ped center is a question of volume. So our pediatric trauma centers, so right now that's Bellevue and Jacobi, have between 100 and just over 100 patients. The volume requirements for level 1 are much higher, and in particular, the particular rule is you must have a full-time trauma medical director that is a full-time pediatric surgeon. I would say, though, and I think it's an excellent question because people between 2 and a 1, from my own perspective, the communities that we serve, Bellevue and Jacobi being the only pediatric trauma center in the Bronx, are well-staffed and do an excellent job serving the communities. But I do think it's an excellent question.
Thank you. Okay, so let's take for a vote approving these applications for verification. So all in favor, please say yes.
Yes.
Opposed, say no. So all the resolutions approved. Thank you so much, Dr. Tepperman, for your time. And this is trauma center is a question that we always get as committee members, board members, and it's nice to see this work moving forward.
Thank you, Dr. Fox.
Great job, Shep.
Thank you, Dr. Katz.
Yeah, so let's do the Chief Medical Officer's report, Dr. Allen.
So, as you know, we are doing many things in the CMO's office, and I take advantage of this time to highlight specific programs. So this morning we will be focusing on Women's Health Program, and the presenter will be Dr. Wendy Wilcox, the Chief of Systems Chief of Women's Health.
Thank you so much, Dr. Allen. Good morning, Dr. Pagan and Dr. Katz and board members. So the question is, I'm talking about the cardio-obstetrics practice at Kings County, and the real question which arose is why focus on women's health? So cardiovascular disease, as we're all aware, is the #1 cause of death in women in the United States. And yet, most women don't know that that is the thing that will kill you. If you ask most people what's the #1 killer of women, often you will get an answer like breast cancer. So we need to make people aware of this risk in the population as well as destigmatize the disease. Next, please. We realize now that conditions that present during pregnancy can have a lifetime of negative effects. Preeclampsia is one of those conditions which is very frequently seen in pregnancy. And what we realize is that after 10 years, even after 10 years of a pregnancy with preeclampsia, women are at increased risk for cardiovascular causes of death after that episode. So it really can have a lifetime of negative effects. Next slide, please. Last month, New York City issued their most recent pregnancy report on pregnancy-associated deaths. That's the maternal mortality report from New York City. And it's issued over a 5-year time span. So the latest one is 2016 to 2020. We know that Black non-Hispanic women have a much higher maternal mortality than other ethnicities or races. If you look at the numbers, it's about 4 times as much. You will hear other numbers quoted, but in New York State and New York City, Black non-Hispanic women have about a 4 times higher risk of maternal mortality than other ethnicities and races. Next slide, please. When we look at the causes of pregnancy-associated death, and I should give the definition here, a pregnancy-associated death is a death that occurs of a woman either while pregnant or within 1 year of the termination of a pregnancy, irrespective of how long that pregnancy will last. So when we look at the just top causes of pregnancy-associated death, we see mental health conditions being the top cause. Cardiovascular, however, is a close second, and you can see that it's divided into cardiomyopathy, which is the lighter blue part of the slide, and other causes of cardiac disease. When we look in terms of causes and then subdivide them by race and ethnicity, we see that for Hispanic women and birthing people, mental health conditions and hemorrhage are the top causes. When we look at Caucasian women and birthing people, we see mental health conditions as the leading cause. When we look at Asian, just people of Pacific Island or Asian descent, we see cancer as the leading cause. However, when we look at Black non-Hispanic women, we see that the top causes of death are cardiovascular conditions, then followed by mental health and embolism after that. Next slide, please. When we look at the timing of death, we will see that over half of the deaths occur between the 43 and 365 days. So that's over the 6-week mark postpartum that we usually considered when we were looking at maternal mortality, and those are the blackened part of the slides. When we look at mental health conditions and cardiomyopathy and cancer, we see that most of those occurred during that time period. So we're really taking a much more focused look, not only at the pregnancy episode, but certainly in the year and beyond that following. Next slide, please. We were just blessed enough to receive funding both from Health and Hospitals and Robin Hood. You can see the amounts there. We submitted a concept to Robin Hood, then we submitted a full proposal, and we were awarded funding over 3 years to start this program. The reason we picked Kings County is because Kings County is located in central Brooklyn, which is a hot spot, the highest in the city for maternal mortality and severe maternal morbidity, as well as among the Health and Hospitals facilities, it has the highest rate of Black non-Hispanic women. Next slide, please. So we have some key deliverables. We have to, in fact, I was reading an article this past weekend for my boards. We know that women will come into pregnancy with pre-existing cardiac disease those are the women who are known. And so those are the ones that we're able to evaluate and then either refer for a higher level of care to our regional perinatal center and or create a multidisciplinary plan around their pregnancy. There's a much larger group of women who are unknown. And this really does create a problem. They will either present during the pregnancy with signs and symptoms that indicate that they have heart disease, which will need to be evaluated and to protect them during that pregnancy and subsequent pregnancies. And there are a group of women who, with these symptoms, will have vascular conditions, hypertension, preeclampsia, like I mentioned, who will go on to progress in the postpartum period and later in life, who really need much more increased surveillance and to know about their disease and follow up so that they don't present later in life with a cardiac condition. Next slide, please. So this is just an illustration of the different types of heart disease. We have ischemic cardiomyopathy, which means weakening of the heart muscle, arrhythmia and hypertensive disorders of pregnancy, which many, many, many of our patients have. I will say with cardiomyopathy, one of the things we are really are trying to institute with this program is to also diagnose women because what we are realizing in the obstetric community is that women are not being diagnosed during the index pregnancy, come back for a second pregnancy, and that's really when they are in great danger because their cardiomyopathy was not diagnosed, and that poses a huge risk. As I said, in addition, we have many, many, many patients with hypertensive disorders of pregnancy who need to be engaged in care and surveillance from the pregnancy and beyond. Next slide, please. So, key takeaways are that we will target patients' disease and or risk factors. As I mentioned, hypertension, obesity is very prevalent in our communities, and diabetes from the prenatal period up to a year, and then tie them into care from beyond that postpartum year. We have a multidisciplinary team, certainly obstetricians and cardiologists, but then all of our partners also in our hospitals. We have made contact with our community-based organizations, Caribbean Women's Health Association and Life of Hope, and we are working on presentations to the community to carry out and beyond so that people will be aware of these increased risks of heart disease. And we are extending our already existing maternal home. One of the questions that came up during the prep session was, what are we doing for mental health disorders? We have a maternal home which does help to diagnose and then refer patients. However, if given the opportunity, we would most certainly expand that to a mental health maternal home as well. And the reason for that is because you can see these numbers are from 2022, but even from 2021 to 2022, we had a 20% increase in mental health referrals, and that they were 23% of the referrals then. It's much higher now. Next slide, please. And this is a picture of Dr. Suzette Graham-Hill. She's a cardiologist at Kings County. She is the director of the program and really passionate and involved with this work. And I'm excited to, after some time, bring metrics from that, because right now we're in the planning stages, but we aim to start in Q1 of 25.
Thank you. Great presentation. Any questions from committee members?
A great presentation, Wendy.
Thank you.
Wendy, is the mental health postpartum depression, or is it beyond that?
It's everything. It's pre-existing behavioral health conditions as well as the peripartum mood disorders. And so, you know, when you have all that, we saw a really, you know, post-COVID 100% increase, and then since then we've seen much more increases, and we do realize that those behavioral health resources are in short supply for everyone. And so through the maternal home, we do a really good job at being able to diagnose and or get people wraparound support to then refer them. If I could wave a magic wand, I would create a special mental health maternal home so that those patients could get even more specialty care and we could help a lot more patients.
Just two comments. Go ahead, Sally.
And Dr. Katz talks about remote mental health being a way to overcome some of our literal restrictions. Is that something that could work?
Absolutely, and we would include that along with, we need to increase our prescribers. We do have a fair, we are the largest provider of mental health services, H&H's, in New York City. So we have a good number of pregnant persons who have pre-existing mental health disease who need to continue on medications. So it really runs the gamut from people who have these pre-existing conditions to those who also have conditions that present during the the prenatal period or perinatal period. So it would take everything, and we're currently partnering with Cornell and many others to apply for an HRQ grant to pilot a program like that, and have some other feelers out about how we can roll something out like that as well.
Thank you.
Thank you.
So, thank you, Jose. I just want to point out, if you look at the slide, which shows from 2001 through 2020, that the maternal mortality rate for Hispanic Blacks has actually decreased. So back in 2001, we were fivefold greater than the Caucasian population. Now we're fourfold. But what's disturbing is if you look at the Hispanic population, they actually have gone up a bit over the time frame. The biggest decrease has been among African Americans. It's actually the slide before this one.
Go one slide before.
Go back again.
Go back,
Before.
back.
It's the slide that looks like this.
No, right, it's the, yes,
There
it's
it
this
is.
one.
Yeah. So the rate among non-Hispanic Blacks has gone from 61 down to 52. Overall has gone down. Hispanics has actually, after having gone down to 14.1, is up to 20.3. So we're focused on Blacks because we have the highest incidence, but we really need to take care of everybody within our community. And the other thing I just wanted to say about cardiac disease, the most frequent presenting complaint is dyspnea. And the providers often say, oh, that's just because you're pregnant. And we miss the diagnosis. So with the work that Wendy's doing in Kings County, and what we'll be doing among all of our teams, and we're all doing our maintenance of certification for the boards, we're all reviewing the same articles, and there are a number of articles on cardiac disease being the leading cause of maternal mortality among non-Hispanic Blacks. Just need to be really sensitive.
Wendy, because of the pervasiveness of racial discrimination and its effect on mortality, I wonder how different this slide would look if it were women of reproductive age. In other words, if you took out pregnancy. In other words, we know that there is tremendous, because of the pervasiveness of racism, we know that mortality rates are much higher among African Americans in general. And it would be, someone must have tried, some portion of it is likely related to, with pregnancy, the demands are higher, the psychological demands are higher, the hormonal demands are, right. So I'm sure that then the disparities and the effect of racism get magnified. But again, I would bet that the general pattern looks the same. But someone must have looked at it. Someone must have looked at.
Yeah, I'm
look at-
thinking about the New York City when they mapped Department of Health, when they used to have the neighborhood reports and they would map it across. I don't remember a graph that looks like that, but
The ideal would be women who didn't become pregnant, but that would be too hard statistically. For that, you'd need a cohort, right? Because you don't know. But if you did women of reproductive age, right, you could even match this by age, right? It would be interesting to know how much is the excess of pregnancy and how much is just the effect of baseline racism and social deprivation on this group independent of pregnancy. Someone must have looked at it.
We looked at longevity, but not by, but probably by gender, but I don't know if we've done it by reproductive age.
Just to your point, I will say that there's an article that I mentioned in this that does not deal with pregnancy, but often when I'm talking about this subject, because it struck me, and it was a longitudinal study of Black women that looked at perceived racism and stroke, and the stroke risk was obviously much higher, and you know, and you know, clearly, I think there's an overlay of pregnancy,
Sure.
right? Because we're talking about vascular, and one of the articles too is separating vascular from cardiac, even though they're lumped together, pre-existing and then unknown, and realizing that there's a lot more about this subject matter, but you're absolutely correct in that, I think we're looking at a window of pregnancy, but it certainly could be overlaid on just,
Right.
what
And it
happens.
does make sense. I mean, stroke is primarily either an embolic or a hypertensive disease, while the cardiomyopathies are harder to characterize, right? That's exactly, I mean, it's like there are 20 different reasons you could have a cardiomyopathy, right? And exactly what these are, you diagnose it based on what the heart looks like, but that doesn't tell you why the person has it, right?
Right. One
What-
of
what
our
was the
goals
cause?
is to just have some baseline statistics for this community. And Dr. Graham Hill anecdotally can tell you the number of women walking around with the cardiac ejection fraction of, low double digits to single digits unknowingly is unbelievable.
Right, people adjust their activities for their ejection fraction, so they don't notice, because they.
Right, and then they show up in pregnancy and they're
Right.
supposed to be, it's
Yeah.
kind of wild, so.
It is wild.
We're excited about
Very
this.
interesting. Thank you, Wendy.
Thank you very much.
Thank you for your presentation. So I'm running out of time, and I'm sorry about that. And so we're gonna accept the chief nurse report, executive report, the chief information officer report, and the Metro Plus Health Plan reports in writing. So thank you so much. And is there any old or new business to come before the committee? So hearing none, the meeting is adjourned. Thank you so much.
Thank you.